I'm going to give a brief lecture just to tell a little story about antenatal corticosteroids, this topic, current recommendations, talk about some controversies. And then at the end of that, in about 15 minutes or so, I'm going to bring back these three very nice OB hospitalists. We're going to bring them back into a kind of interactive conversation. And we have some designed questions. We're going to have some interaction and some conversation together about this particular topic, where we're at today nationally, where we could go tomorrow, and what you as the OB hospitalist could and maybe should be doing and thinking about in your own role in your positions throughout the U.S. So I'm going to say briefly goodbye to my friends, and I'm going to bring them back shortly in just a moment. All right. So today, I want to tell you briefly just a little teeny bit about myself so you know who you're listening to. I'm a maternal fetal medicine physician. I spend 99% of my life talking to pregnant patients, just like you do. We have a large practice in the state of New Mexico. I really enjoy doing outside work and have had a tremendous amount of interaction and fun with Hologic, CCSI, and Philips, doing all kinds of different research, consulting, and speaking engagements. Today, we are going to talk about the published clinical studies, not all of them, obviously, because we have a short period of time, but talk a little bit about steroids and why we would want to utilize these medications, talk about recent recommendations, some very, very pertinent and new controversies that I'd like you to be aware of, and then try to bring in what's the role of the OB hospitalist and how do you participate in this decision? This medication, antenatal corticosteroids, comes in a couple forms, betamethasone and celestone, or betamethasone and dexamethasone. I think we probably would agree this is the most effective medication available for essentially fetal therapy that we have in our toolbox today. It is incredibly powerful and beneficial to helping the preterm fetus if they actually are born preterm. However, there's still a lot of controversy about this particular topic, and it's been surrounded by a bit of uncertainty. We use this steroid medication because it helps to benefit something called respiratory distress. And RDS is a very common cause of neonatal harm, affecting half of babies less than 28 weeks, half that are extremely low birth weight. And the effects are due to really, as a preterm baby develops, they have 5 stages of lung development, the final stage ending at age 2 of life. They have surfactant deficiency. Those type 2 pneumocytes are not creating sufficient surfactant to lubricate the lungs. And that leads to respiratory distress syndrome. And the issue with this type 2 pneumocyte, I know you're like, gosh, this guy's talking about medical school stuff. The problem is that when we, are stressed or exposed to exogenous steroids or cortisol, the farther we get away from that exposure, the type 2 pneumocytes, they stop responding. And so the production of surfactant goes down. And so the timing of this medicine is really, really important. And we know that from the first ever study. This was performed by Graham Liggins, 282 moms in 1970s, and basically does exactly what we do today. Give a mom steroids if preterm birth was anticipated, repeat it 24 hours later, and then see what happened. And what Liggins found in this landmark trial is that if the mom did not have steroids, got the placebo, a third of those babies had RDS versus 3% if they did get steroids. So very powerful impact of antenatal corticosteroids for a pregnant person who's going to have an imminent preterm birth for whatever cause, preeclampsia, PPROM, preterm labor maybe. But what Liggins taught us is that there's a timing associated with this as well. If the patient received the steroids and then the baby delivered between 2 and 7 days after that dosing, that is the time when he saw significance in his study. If it was given too quickly and the baby delivered too rapidly, there was no effect. But if we didn't time things correctly and the baby delivered many, many weeks later, we saw no statistical impact for that preterm baby. And that's going to be important. So I'd have you remember that slide, please. 50 years later, ACOG, our larger, parent professional society, the American College of Obstetricians and Gynecologists, has produced an ongoing reiteration of this particular committee opinion. And I like to show this because it's highlighted in, black print, blue highlight, yellow highlight, red interim updates. And the reason is that this topic has changed a lot over even the last 10 years. One thing that ACOG has never moved away from is that antenatal corticosteroid administration prior to a preterm birth is one, if not the most important antenatal therapy to benefit that newborn preterm baby. And we can lean on Cochrane for showing that steroids reduce RDS, it reduces infection, it reduces bleeding in the brain for a newborn baby that's preterm, and incredibly important, reduces death. And has an effect in reducing NICU admission as well. So I think globally we agree this medication is profoundly important and impactful if a fetus is going to be born preterm. Today's current recommendations from ACOG are things that you do every day, and I'm sure you're familiar with this, but as a review, we should give a single course of steroids to a pregnant person 24 weeks and 0 days to 33 and 6 if they're at risk of imminent preterm delivery in a week, 7 days. And then we added that at 34 and 0 to 36 and 6, if a patient has a suspected need for imminent preterm delivery or is in preterm labor with imminent delivery anticipated, again, within 7 days, they should receive late preterm steroids. And also, periviably, 22 and 0 to 23 and 6, if the patient, the family desire full intervention, again, if delivery is anticipated within 7 days, we should administer antenatal corticosteroids. Why is it so important that this needs to be done in a properly timed manner? And that goes back to 1970. Dr. Graham Liggins told us that it's because that's when the medication is efficacious. The longer we have a baby in utero and we've administered steroids, the less the effect. So if we give and take that opportunity and administer steroids to a patient and she delivers on day 14 or 20, the effects disappear. The benefits of steroids go away. RDS rates rise, and we lose that opportune benefit of this medication. This is not just Dr. Ruma and the group of SOGH members that are with me today saying that we should try to do better. There is profound interest in this particular topic. The Society for Maternal Fetal Medicine in 2022, so just literally 2 years ago, gave us a special statement that's entitled Quality Metrics for Optimal Timing of Antenatal Corticosteroids. And this statement agrees with ACOG that steroids are very important, but also that they're optimally effective when they're administered within 7 days before a preterm birth. And SMFM goes on to say that, we know we're not doing a great job with this, that only 20 to 40% of preterm infants receive steroids within this special window of a week. And they lean on 2 studies, and I'll go over them. This is by Razaz, is from Canada. In a large, over a decade study, only a fourth of patients were optimally timed. The mom got steroids, and the baby delivered within that time frame of 7 days. Huge rate of suboptimal utilization. And so this study from Canada in general would say that there's a lot of work to be done on thinking about how we can better improve the timing of antenatal steroids. And then another study from the British Journal a couple years later says that in general, about 40% of pregnant people receive steroids in an optimal timed 7-day window. But this study's kind of interesting. They actually split out kind of why we are giving them as clinicians. Why did the patient present, and did she get steroids, and was it timed appropriately? And you can see, like, for severe hypertension, we're pretty good. I mean, we're timing steroids like 60+% of the time correctly. But maybe for like preterm contractions, preterm labor, we're only accurate like 35% of the time. And then very interestingly, if a patient's asymptomatic, surprisingly, a lot of patients are getting steroids in asymptomatic states, but really, really unlikely that you're going to time it correctly if a patient has no symptoms. So the SMFM organization, my subspecialty organization, puts out this paper just 2 years ago, recognizing that in the US, we have low rates of optimally timed steroids. And we know that this has been a cause due to prior Joint Commission perinatal core measures that really cause clinicians to liberally utilize steroids in almost any setting. But that measure has gone away. And SMFM wants us to time the steroids better so that we actually maybe see improved benefit for the baby. But also there's an evolving field of literature that would suggest that when clinicians, myself, you, don't time the steroid administration properly, there may actually be a heightened risk of adverse perinatal outcomes, some of which would be a higher rate of NICU admission, higher rates of small for gestational age infants, and then highly concerning an associated risk of mental, neurocognitive, and behavioral disorders. This is a snapshot of PubMed. I encourage you to do your own PubMed evaluation just so you make sure that I'm not sharing falsehoods with you. There are numerous articles available, probably in the number of 90 plus articles now on PubMed. If you put in the word antenatal corticosteroid as a keyword and neurodevelopmental outcome, you're going to gather a lot of different studies. Things like from British Medical Journal, neurodevelopmental disorders among term infants that were exposed to steroids. An article we're going to talk about briefly from Finland by Raikkonen, neurocognitive sequelae of antenatal steroids, long-term childhood outcomes. There is a keen interest in the research realm as to if a patient, while pregnant, receives antenatal corticosteroids, this very beneficial medicine, when used and timed correctly. But there's a lot of interest on this medication on, can it cause harm to a baby if we use it maybe too frequently and not in the best setting? I'm going to run through just a few studies so you understand the premise and the concern on this. The first landmark article that brought this concern to light was from Finland, Katri Raikkonen. This is an epidemiologic study looking at the Finnish medical databases. Interesting because they're able to tie the mom's chart to the baby's chart. And they looked at women that received steroids during pregnancy, and then did their child have any mental or behavioral disorder from birth to 9 years of age diagnosed and added to the child's active problem list in the National Electronic Medical Record. They had nearly 15,000 children exposed to steroids. Interestingly, 45% were born at term. So why did they get steroids? Because they delivered at term. And half the time they did deliver preterm. But this begs the question again that even in Finland, just like us, we're not timing steroids correctly and as well as maybe we could. The entire cohort showed a risk, if steroids are administered in pregnancy, of some mental or behavioral disorder. But then they dichotomized that by when the baby was born, term born versus preterm born. And fascinatingly, if we give steroids preterm and the baby delivers preterm, there is no associated harm to the baby. However, if I give steroids at 25 weeks and the mom delivers her baby at 40 weeks, there is a suggested association of mental and behavioral disorders. And so that was pretty striking, and is why SMFM's taken interest in this. Additionally, they followed this study up 2 years later because they received some criticism about what exactly were the mental and behavioral disorders. And so they expanded the age from birth to 12 years, and then they really dialed into speech and scholastic and pervasive developmental disorder and vision and things as severe as cerebral palsy. And interestingly, in this follow-up study, they found still the same effect as the initial epidemiology study. Overall cohort, if a pregnant person is exposed to steroids in utero, that baby has a higher chance of developmental and neurosensory disorders. And again, the same phenomenon when they dichotomize the population, the term-born child is the one, if I give steroids at 26 weeks and that patient goes on to deliver at 37, 38, or 39 weeks, and we're not optimally timing the betamethasone, there is an associated potential neurodevelopmental outcome, and really for everything. My wife's a speech pathologist, speech and language disorders, scholastic skills developmental disorders of motor function, cerebral palsy even associated in this if we expose in utero, preterm, and then deliver at term. So that's a quick snapshot of information from Europe. But there's also information coming from the United States, which again also alarmed and brought this necessary attention to SMFM, making this quality paper pertinent and important. This is a group from Indiana, Dr. David Haas, Alexandra McKinsey, published in AJOG just a few years ago. So women that came for threatened preterm labor, if they were exposed to steroids or not, what were kind of the outcomes? And they were looking at kind of immediate potential harms to babies by poor timing of steroids. Did it cause TTN? Did it increase actually NICU admission, which you would think it would diminish? And then did it create a small for gestational age size infant? 5,300 pregnant women, a third of them got steroids at around 32 weeks, and 50% of them delivered at 39 weeks. So again, in US data, we're not timing correctly. And what we found, what they found in Indiana, is that the patient who received betamethasone preterm and then delivered a child at term for an evaluation in our triage units for threatened preterm labor, there was basically an increased, 100% increase, 6 to 12% increase for NICU admissions, as well as for small for gestational age infants. Takeaway from Indiana is that when we think about giving a patient steroids for threatened preterm labor, they suggest we be judicious. And they say in a large diverse population, there may be, again, just like Finland, adverse outcomes for newborns who go on to deliver at term who are exposed to preterm steroids. This has been looked at again in the United States, but only in the late preterm setting. So Dr. Janfi Bannerman, 34 to 36 and 6, late preterm steroid study published in the New England Journal of Medicine in 2018, looked at her children in that study and saw, did they have any issues? Out of the 2,800 patients, only 949, so about a third of the population completed the study, but they found no difference in neurocognitive outcomes. So while there's concern from Finland and Indiana, at least in the late preterm setting, we may have less concern about this. This really is the only study evaluating this particular age range. And this is the published paper again in JAMA just out this year. Late preterm steroids does not appear to be associated with adverse childhood neurodevelopmental outcomes up to age 6. So SMFM. I mean, how do they conclude and why did they write this paper? If you've not read it, I would encourage you to look at it. SMFM is asking us, we know that we're not timing steroids as well as we could. And they're going to ask us as clinicians to thoughtfully evaluate the real risk of preterm birth within 7 days before we choose to give steroids. And they ask us to avoid administration of antenatal corticosteroids in patients whose risk of preterm birth is low. And they would characterize those people with low risk as a patient with contractions, preterm labor, and a negative fetal fibronectin test result, as well as patients that are asymptomatic, even if they have a short cervix and they're asymptomatic. And why I love, and I'm really excited to be joined by my SOGH members and all of you today, is that we need facilities around the country to start tracking this rate of optimally timed steroids. SMFM encourages facilities to develop pilot quality improvement projects, and we want to ask you to embark on these if you're willing. So how do we improve? And this is where I'm going to bring in my friends here. We have, this triage room, which you're all familiar with all throughout the country. And we can assess patients' history. We can talk to them about their symptoms. We can do cervical exams. We can do ultrasound. We can do a fetal fibronectin lab test. We know cervical exams, while very common, they're not the greatest predictor of preterm birth, especially if you're going to try to make a decision about steroids on that alone. If a patient's a centimeter dilated, almost all of them deliver a week later, so we probably shouldn't rely solely on digital exam. And even if she's 2 centimeters, 70% of those patients go on to deliver weeks later. Fetal fibronectin is a lab test. It's objective. It was designed to be a rule out test. It has a high negative predictive value, meaning that if a swab is collected, takes 10 seconds from the posterior fornix, sent to a laboratory, 20 minutes on a machine, and it gives you a negative result, there is a 99% chance she doesn't deliver in 7 or 14 days. So if a negative FFN is done for a patient, we should not be giving steroids. And this is in alignment with SMFM's statement. And then we have cervical ultrasound. As an MFM, we do a lot of ultrasound, transvaginal cervical links. If we're doing this in practice, we should know how to do it. Cervical link should be looked at carefully. This is a cervical link that looks totally normal at minute 1. But as we talk to the patient, evaluate her, on minute 3 or 4, her cervical link's actually markedly shorter. And this is now highly abnormal. And so we want to know and use these tools properly. And the tools probably work best together, especially when we're talking about pulling the trigger to give steroids. So alone, a short cervix under 25, your positive predictive value of delivery within a week is like 12, 13%. Fibronectin gets us maybe to about 30% if it's positive. But if we put them both together, now we're at the kind of 50% threshold. What do you see happening today? And I'm going to ask my friends here in just a moment what they see in their own environments. But I'll have you think about that in your own accord where you're working. I mean, what are you doing? This is a study from the Netherlands. In the Netherlands, when they had a cervical length over 30, 1 in 100 of those women delivered in a week, but a fourth of patients received steroids. This is not something we should be doing today. 10 to 30 millimeter, this kind of gray zone, people use all kinds of different protocols, but between this gray zone, short cervix, it's abnormal, but she has a negative fibronectin. 3% of these patients delivered within a week, but almost all of them, 2/3, got steroids. Positive fibronectin in an equivocal cervical link gets us to about 20% in a week. 90% receive steroids. Under 10, 65% deliver in a week. So extremely short. This is the groups that we should be giving steroids to. And the reason they work better together is we often say under 30 millimeters is abnormal on a cervical link. But if her fibronectin is negative, only 11% of those patients deliver in a week. So it's really important that we add these two so we don't pull the trigger. We need more information, and that's what we're going to discuss. All right. And then this is under 15 millimeters where we're getting to a PPV 75%. All right. Last but not least, snapshot of what we see today. So 2017, Sean Blackwell, former president of SMFM. So you have an idea that we're not just boring you with random information. We really have an issue in the US. 5 insurance databases, 23,000 patients, 24% of them are admitted with preterm labor symptoms because they're like 4 or 5 centimeters dilated. 76% are discharged home. But interestingly, the majority of them deliver many, many days later, but a fifth of them come back real quickly and deliver preterm. This group of people, what did we do to them? Were they treated appropriately, evaluated appropriately? We just talked about a bunch of different tools. In this study by Blackwell, former president of SMFM, 80% of women had no fetal fibronectin, an objective laboratory test with an incredibly high negative predictive value, nor did they have a vaginal ultrasound, which also can assist in predicting what may or may not happen. And so we definitely have an issue, and we need to protocolize our care. And so we're going to talk a little bit about protocols in a moment with Dr. DeMartino and Dr. Pagano and Dr. O'Daniel. But our goal is that we need to really think about how we protocolize care. What do you have available in your system today? Do you have only a lab test? If that's what you have, wonderful. Please utilize it all the time and frequently. If you're in a sophisticated setting, you have trained people that know how to do vaginal cervical links, and you want to do that and incorporate fibronectin when the cervical length is short to make a decision about what to do with that short cervical length, wonderful as well. And if they're profoundly dilated, then we definitely need to expose those patients to steroids. All right, so there's questions I have. I am going to ask Dr. DeMartino, Dr. O'Daniel, and Dr. Pagano to turn their cameras back on. I'm going to stop sharing. And we wanted to have just a conversation. And I also wanted to make sure, because we have about 100 of you guys listening in today, which is awesome, and I'm thrilled with that. But I wanted to ask these guys these questions and maybe have them each answer a little bit, because I've taken some time to talk. So thank you again, guys, for joining. You're all OB hospitalists. You work in a variety of different locations. Can I just ask, based on kind of the information I've provided you already, these protocols and these labor evaluations, I mean, what do you each individually see being done when patients present with preterm labor at your institutions or maybe other institutions you've previously worked at? Could I maybe start with our immediate past president, Dr. Julianne DeMartino?
Thank you. And thank you for having me here today. This is really an exciting talk, and I'm grateful to be here. So starting out, I have been a hospitalist now since 2013, and have worked in various institutions, from very, very small community hospitals to medium size, all the way up to large academic centers. The vast majority, I would say, of all of the centers I worked at, regardless of the size or location, has mostly relied on cervical exams, contractions, to determine whether or not to determine if the patient has preterm labor or not. Um, the majority are being admitted. They're being evaluated for things such as UTIs. Are they dehydrated for illness? Are they bleeding? Are there signs of abruption? So all of these things are going on while we're watching these patients over time. But I'm seeing this approach the most, and steroids given under the conditions of, the cervical changes. Some institutions have thresholds, whether it be 2 to 3 centimeters. Some do not, but that's the vast majority that I have seen since 2013. The only really detailed protocol I have seen is actually when I worked with Dr.Trina Pagano, and in some of those institutions, such as the one that she works in, they have a much more detailed outline as to how they approach these patients. So that has been my experience.
Cool, thank you. Can I pass that on to you, Dr. O'Daniel?
Sure, that is very similar to mine. I've been a hospitalist since 2013 as well. And prior to that, I was a generalist in a very small town. So one of our biggest issues that I think that can affect people is just access to resources. So in a small hospital, in a critical access hospital, I was doing cervical exams. I had access to fetal fibronectin, but it was a send out. And so that wasn't nearly as helpful to me immediately, and I didn't have access to a bedside ultrasound with a vaginal probe. So I was really limited in what I could do to assess. But I was really grateful to be able to work closely with my colleagues in the MFM setting in Oklahoma City, which is actually where I am now, and work with them much, much closer. And now in a tertiary center where I have access to fetal fibronectin, just like Julianne mentioned, we are utilizing that on probably almost everybody. We certainly are collecting it on people, and then doing the exam and finding that out. And I would say we're a little bit more of a mix as far as whether we're using cervical length or not. That certainly is not as protocolized as Dr. Pagano is, and I'm super envious of her algorithm because I love how well it's laid out, and I think it's something that hospitalists can really emphasize or kind of impact. But we're doing a little bit of a mix too, and whether or not they get admitted is just based on location from the hospital, whether or not we have immediate concern, also patient compliance and sort of shared decision making. So.
Okay. All right, Dr. Pagano, your name's been brought up now twice by both of our guests here. Not to put you on the spot, but I mean, what do you do in this realm of preterm labor evaluation, or what have you seen in your career?
In my career, so of course, in my training way back when, we only did cervical exams and cervical change to guide us. And I, like Dr. DeMartino, have worked in a variety of settings, ranging from, rural Western Pennsylvania to tertiary care centers, with a variety of resources available. Uh, I cannot take credit for this protocol. It is, it was written up by Rose from out of the Mayo Clinic quite a while ago. When I arrived at Cleveland Clinic Akron General, the MFM that had been here had already initiated utilizing the protocol in our department. All of our attendings who cover the OBED are trained to do cervical lengths, and our residents are also trained. They used to do the clear training, but additionally they have a special ultrasound rotation that they learn to do this. So we utilize cervical length for those who went on cervical exam, their cervix is less than 3 centimeters. Greater than 3 centimeters with the presence of contractions is diagnostic for preterm labor. But under 3 centimeters, that's when we go to the cervical length. If our cervical length is, and we use the Rose paper, the 16 millimeters to 29 millimeters. If it's within that range, then we send our fetal fibronectin, which we have collected prior to doing the vaginal probe and the cervical exam. And then the negatives, we discharge home after a little bit of time, and then the positives, kind of depends. That's where your clinical decision making comes into play. But most of those get steroids, and of course, anybody who's 3 centimeters digitally and greater then will also get steroids. So that's I will tell you, I was a non-believer when I first arrived, and I have been totally a convert. I was worried about all the people we were sending home and who was going to come home, who was going to roll in, dilated, and we weren't going to get their steroids in. And I could tell you, I've been here 6 years, and that is not an issue at all.
Can I ask, just in follow-up of maybe each of you, do you think in your field, I mean, as OB hospitalists, you guys are on the front lines and dealing with, every emergency, catastrophe, crisis of obstetrics. Do you think just in general that facilities should be using protocols? Are they of benefit? What's been your experience with that? And then might just toss it back to Dr. DeMartino.
Yes, I think the protocols should be instituted. I mean, we have seen success in so many other ways, our hypertensive crisis, our hemorrhage. So we use these protocols day in, day out, and we've seen so much success with that. And for whatever the reason being, this is something that has been lagging a little bit, I think, in my opinion, just from my experience in different institutions. And yes, I think even if it's a small protocol, it doesn't have to be great big. Maybe you don't have a vaginal probe ultrasound in your facility. You may not have that training, but looking towards doing something and following it consistently, I think can make a really big difference.
Okay, thank you. Dr. O'Daniel?
Yeah, I think, if you ask 5 OBGYNs, whether you're a hospitalist, MFMs, or a generalist, you're going to get 10 different answers on whether algorithms and protocols work. I'm a firm believer that algorithms keep us honest. And I don't feel like algorithms should exist to keep us sort of narrow-minded, but really all very uniform and routine in doing something well for our patients, but then utilizing what they're clinically presenting to us to sort of alter if need be. So I think this is one of the ways that the OB Hospitalist has been really impactful and still remains the ability to be extremely impactful is that we as a core group can focus on those algorithms and make sure that we are helping re-educate, refresh, and keep everybody in the hospital, nursing staff and physicians on target with these algorithms and kind of all keeping us moving forward in the same direction. So I am cautioned, and I'm cautious to say that algorithms are the way to go, black and white, but I do really feel like they keep us honest and then have a conversation with each other and say, okay, this isn't really following this algorithm, and then having a mindful conversation about why we might be altering or going off that algorithm. So I love them, but love them with caution to make sure that we are using our clinical diagnosis skills.
Yeah, understood. And then I'll open that one up to you, Dr. Pagano. You said you were a convert. You obviously were working somewhere different and then came into another environment maybe. And can you tell us a little bit about what that experience was like?
So yeah, I mean, I've always been an algorithm kind of girl. I always have been. I believe in, in obstetrics. There's so many, you know, things that can happen that are unpredictable, and any place you can standardize, please standardize. So that's my belief when it comes to preterm labor. As Dr. Daniel, you can have a doc examine and then the next doc, and there's great variations in your cervical exam. So what Dr. DeMartino said about finding, it doesn't have to be my protocol. It just make it some sort of standardization. But I think the other thing is that when we standardize, especially in the OBED, which is my realm, if you have trainees, and if there isn't some sort of standardization, it confuses your trainees. Okay, and you want to make sure your standardization is based in evidence, but it confuses your trainees if everybody's doing something different. And then secondly, it provides inconsistent care for our patients. And in a time when we want to make sure there's no biases in medical decision making, you're providing the same care for every single patient who walks through the door.
Yeah,
I
can we,
also,
sorry, go,
I'm
yeah,
sorry, I don't
go for it.
that I just feel like what you said was so crucial, and I think is one of the things I've loved the most about doing this job is that it really opens up the collaboration between the entities, right? So we're seeing this sort of shift where MFM colleagues are not on the floor with us as often in their consultants. And having these algorithms really brings us together to have discussions about what the current evidence is showing, and almost, a journal club, if you will, if we were back in an academic setting. And I'm in a tertiary center, but it's not technically considered an academic institution, but having algorithms like this, and Julianne is 100% correct that I feel like preterm labor has sort of lagged behind, but we talk about this all the time with hypertension and hemorrhage, and we really makes us stay up to date on what exactly evidence we have. And so that's one of the things I love about that is it opens up the lines of communication between the two groups.
Yeah, I would totally agree on that. The can can we just expound, Dr. Pagano? Um, do you think patients recognize a difference, or I'll open it to all of you guys. I mean, we heard equitable and inclusive and not having bias. What is do you think a protocol assists and benefits the patient? I mean, what do you have any experience or story or anecdote about that?
Oh, I don't know if I have an anecdote, but yes, I feel, and quite honestly, we tell them, here's our protocol. We say that up front. We have, we don't shy away from that. But this is our protocol and how we proceed with preterm contractions, and we lay it out for them.
Okay. Dr.
I think that
DeMartino?
I think the patients are much more reassured too when you are transparent like that and say, this is our protocol, this is why it's evidence-based. We're not just making these arbitrary decisions on your health care and your care and the care of your baby. So I think that the patients have much more confidence in what we're doing. And one of the other comments I wanted to make too, to add on to what Dr. O'Daniel said, is it not only bridges the communication and the care that we have between the hospitalists and MFM, but also the generalists, because not always, is the hospitalists and the MFM the ones who are making the decisions as well. Our OBGYN specialists out in the community, we're there to serve their patients and to help them as well. And I think that these protocols help bridge that because communication is just huge. And the communication, again, as I said, with the patients and being transparent is hallmark.
Yeah, I really like Dr. O'Daniel's comment about the journal club, education and communication. And then I know, Dr. Pagano, that you had, from prior conversation, your consultants, maybe somebody like me, a MFM doctor, you don't really have to call that person and ask for permission to do things, which is actually very different. Could you talk a little bit about so they've gone through the protocol. What are the next steps then? I mean, who makes those decisions? I'd like to start with Dr. Pagano, and then I'll come back to the other two.
Because we have buy-in, certainly from our MFMs and the rest of the department on this protocol, we are able to walk our way through until we get to disposition. And so when I say we, I'm talking about my OB hospitalists and the residents basically do the assessment. We all the management, we come up with a disposition, and whether that's going home or get admitted, that is done by us. Very, basically we make that call for either the admission or the discharge. Once the and we also at that point give steroids. So if they get through the algorithm to where we're going to admit them and we make them make the diagnosis of preterm labor, then we put the order in for steroids. And I'm only talking about the under 34 weeks. Okay, I'm not talking about the late ones.
Okay.
And then once they get admitted, we call our MFM and say, here you have an admission. And they take it from there. Magnesium we all kind of know who to give the magnesium to. So we will also initiate magnesium in our OBD as well.
Do you recollect how long or what was involved to come to this consensus and this approach at Cleveland Clinic?
Uh, I unfortunately, like I said, I can't take credit for it because it happened before I got to Cleveland Clinic Akron General, one of the MFMs instituted. I mean, I know the paper came out in 2010, which is a long time ago, but nothing better really has come out. But also, that protocol has been substantiated by all over the world, really, by papers all over the world, including a systemic review. But I don't know. I can get that information, but
Can I
when
ask Dr. Yeah, can I ask Dr. DeMartino and Dr. O'Daniel? Obviously, we have one site, and you guys have talked about other sites where there is no consensus, and it's been lagging, as you mentioned, DeMartino. I mean, why do we think why is there a lack? I mean, I guess maybe we understand why, but what are some of the impediments, or where do we how can we make improvement in this realm to get consensus, so we could have this consistency in our organizations?
Honestly, I think that we have focused in on other areas such as hypertensive crisis and obstetric hemorrhage, because a lot of that came from our hand being forced a little bit. I hate to say it that way, from the Joint Commission.
Yep.
So we started focusing in on those, but it wasn't necessarily preterm labor, although albeit at one point the Joint Commission made that a quality metrics, right? But they didn't make it to the point where we had to consider, is that individual going to deliver within the next 7 days? So I think that maybe that might be why it's lagging, but now this evidence is coming out. The Joint Commission pulled that quality metric back in 2020. And so now I think that we're starting to go, oh, wait, there is a negative side effect to this.
Yep.
And maybe we should be looking at this deeper. And I think that that's what's calling this forward now.
Okay. Dr. O'Daniel, any thoughts on that one?
Yeah, I agree with her. I feel like it's really I think it's when you've learned something, this is such a horrible cliche, but it's hard to teach an old dog new tricks. And I feel like when we think something is working really well, and we see a lot of evidence coming at us, sort of drinking from a fire hydrant, right? We're trying to be mindful of making sure the decisions that we're making is just not on a pendulum in the fact that we just want to stay consistent. I think we're going to keep saying this throughout this conversation because we've got 3 OB hospitalists here, but I really do feel like our job is to be mindful about bringing the pieces together to show that this is in fact working. We have the ability to do um, to implement these protocols in a way and be mindful as a liaison to these protocols and the generalist. And part of that is about working as a team and creating that collegial respect for one another. And it's sort of like what Dr. Pagano said, we make those decisions in the OBED. I'm not calling the generalist to ask permission. I'm not calling the MFM to ask permission. I really am calling and saying, I've evaluated your patient. This is the steps that I have done. This is where I'm at. I'm either admitting or not admitting. Now, if there's a question because it's not very clear to me, then I call and have an actual collegial conversation with that generalist about, hey, this is not very clear, and I'm kind of leaning this way. Do you have a preference? Do you know this patient? Can we make shared decision? Can I talk with your patient about this? And that's kind of how we do that. But I think that the responsibility, especially for those of us with an OB/ED, lies on the OB hospitalist to make sure that we're taking this evidence, that it's very clear that something is in a really impactful medication, that it can be harmful. And so let's utilize this in a way that maintains safety for our patients. And I feel like that's our job.
Yeah, I would agree. Let's use that as a stepping stone to maybe some differences you guys see around the country and some benefits and this role of the OB hospitalist. Are you no? I mean, in this particular topic of preterm labor evaluation, I mean, are there differences that you've witnessed and seen? We have a lot of people across the country listening. You know, OB triage, labor and delivery, an OB/ED, a tertiary level center, an academic center. What's your impression? I mean, is there an approach that's better? Is there something an approach we should strive towards? You guys are any thoughts on that? And Julianne, maybe I'll let you start with that one.
I would go back again to have something standardized depending on the resources that you have. I can honestly say that I have not seen that much of a difference between a triage and an OBED when it comes to evaluating preterm labor, but that's just my experience. For instance, at the institution that I'm working at right now, we are still considered a triage. But we have a very robust system of all different types of protocols for the individuals who may come through our triage area. So I don't know that there's a difference between triage and OBED for everyone, but for all of the others who might be in smaller communities, I think it's based on their resources. Again, I have to go back to that.
And then Dr. Pagano, I know you've done research on the benefits of an OBED and the in that scenario. Can you make a comment on this particular question?
It wasn't research, but it was more of an expert opinion paper. But yeah, so it's just it talked about a lot of these things about the consistency of care, standardization, having a process, having a doctor in-house, laying eyes on the patient and doing that disposition rather than the traditional triage, which is not what Dr. DeMartino has at her institution, but the traditional triage is that the primary OB was called in at their office or at home, and the nurse gave the report or the resident gave the report, and the decision making was made primarily over the phone without laying eyes on the patient. So the beauty of having an OBD is you have to have that hospitalist laying eyes on the patient, assessing the patient, and they're right there in the building. So I think that's one of the advantages of having an OBED. And the other
Okay.
things are just uh, while we don't have studies on patient satisfaction, having the patient come to an OBED where you do have obstetricians rather than an ER doc seeing you, would suggest that patients would likely be more satisfied with their care, their emergent care.
And Dr. O'Daniel?
Yeah, we actually, this is near and dear to my heart. We just opened up an OBED at my facility. We are about 6 months in. So, anecdotally, I could say across the board, it has been such a eye-opening experience. I feel like I wish we had done it sooner. I feel like we're always behind the game. Not my facility, but it just seems very intuitive that we would do something like this. And now that we're doing it, I'm thinking, man, there's so much that we see on a daily basis that it's so nice to have an obstetrician there for the emergency, for the counseling. I think patients get more one-on-one care when they have a crisis and they have lots of questions. The nurses feel really well supported. We do a lot of educating in the OB/ED with our nursing staff. We have students. I know that general ED docs appreciate allowing us to do our thing instead of having to do that over the phone. So, in general, not even just for preterm labor, but for women's health care, specifically obstetrical care, I think it has been such a game changer for me, and I am a huge advocate. Um, just to briefly answer one of the questions that somebody had asked about whether or not you'll get access to this lovely protocol that we keep talking about, Hologic will be sending a recording of this, and then once we get the sort of approved algorithm, that will come with that process for you guys. So you will have access to that after this recording, and it'll be in the next coming weeks or so.
Cool, thank you. And maybe since we're talking, I mean, as an MFM, looking at places to work around the country, definitely included very high on my own personal selection criteria of a facility I wanted to work in was the very placement of an OB/GYN hospitalist program. I concur 100% with each of you that an OB/GYN hospitalist setting, in-house obstetricians, definitely distinctly provides a higher level of quality of care for patients. And I think on that theme, before maybe we embark on a couple questions from the audience, I might ask each of you as leaders in your organization at SOGH, what is the role of your professional society, SOGH? What are some things in the future that, may come forth on this particular topic? Dr. DeMartino?
We have so many resources at SOGH for OBGYN hospitalists that I hope that all of you will take advantage of. We have our core competencies that you can rely on as far as looking for information, evidence-based care. We have our new clinical consults and guidelines that we just recently launched. And that library of information is just going to continue to grow. So hopefully that will be able to help you. SOGH Connect is a forum where you can talk with other individuals who are OBGYN hospitalists across the nation and share what you're doing and get information and learn the different ways to navigate with leadership, getting buy-in. There's just so many resources when we all pull together. So those are some of the things that I would recommend that you can get from utilizing SOGH and its resources.
Okay. And then maybe Dr. Pagano and Dr. O'Daniel, could you, for the OB hospitalists out there, I mean, that maybe is not working and is such an established and communicative and collaborative place, I mean, what some ideas and suggestions, what is that their particular role and why is it so important? Dr. Pagano?
Well, it's incredibly important. You have to start somewhere, first of all. But I think if you're committed to evidence-based practice and you bring that to your hospital, wherever that is, and again, I've worked in rural areas, and you apply that and you lead by example, I think others will very quickly see what kind of impact you can have on a department.
Okay. And Dr. O'Daniel?
Yeah, I feel like it's really those rural areas that the hospitalist can benefit from SOGH because it can feel very isolating and a little bit in your own silo when you start this. When I began, I really didn't even know what the job entailed. It took a lot of communication between myself and the generalist to make sure we're building that trust. And if you're in a place where you have low resources, SOGH is just a gold mine of not only resources, but networking for people to give you ideas, just like Trina just said. It's like we need to stop trying to reinvent the wheel and recognize that people are doing this on a regular basis and have failed and then learned from those failures and gotten better. And really as a whole specialty, I think we could do better at that to help each other out. But I think specifically with SOGH, we are still small enough that network has been some of my shining moments when somebody has helped me because I didn't know how to do something. I've reached out to my network and they've directed me or just advised me and I could talk with them. So I think SOGH is shining in that moment because it can really show how much you can impact in your day to day as a hospitalist, no matter where you're at.
All right. Well, thank you for that one. I might take a couple questions from the audience. Dr. O'Daniel, you answered this first question that any chance we can get a protocol. Yes, we definitely will share the slides presented today. Happy to share any protocols. The study that Dr. Pagano is mentioning, again, Mayo Clinic, Dr. Rose. There are numerous other protocols from Dr. J. Imes, Ohio State, the Marchadimes, etc. As an MFM, I think you guys all have said this, there's different ways to skin a cat. And the approaches may need to be refined. If you are in a rural location and maybe the only option you have is a in-house fibronectin test, then we maybe want to use that all the time. If you're in a sophisticated tertiary level center, you have trainees and you have a protocol that you can follow, we might actually make the biggest impact by following that specific protocol. And then the other question, I might let you guys answer as well, but I'll throw it out there. Is cervical length reliable only with a vaginal probe? That's right in line with the MFM. And what they go on to say is we sometimes have ultrasound providers measure cervixes with a abdominal probe and then report it, but can that be used reliably for determining the need for steroids and managing further care? Happy to address that one unless you guys wanted to take that. Okay. Yeah. Abdominal probe approach, definitely not the worst thing in the world if that's all you have. However, maybe the upper threshold should be different, not 3 or 2.5. Definitely study would show that 3.5 centimeters transabdominally, that below that we should reflex to a vaginal cervical length. The point of transvaginal cervical ultrasound is it puts the camera very close to the cervix, right on it. You're going to get way more reproducible, less inter-observer variability by doing them vaginally. So if you are going to embark on cervical links, using the transvaginal transducer, personally as an MFM, and I definitely the SMFM is going to agree with that, would be the approach on that one. Before we conclude, we got 2 minutes left. I just want to share one last little bit here, guys. I really want to thank my members, Dr. DeMartino and Dr. Pagano and Dr. O'Daniel, for taking time out of their busy schedules today to share their expertise with the SOGH members and other members throughout the country. How do we improve? I think we have to study the literature. Definitely have to be thoughtful. We have to use the tools that we have in front of us. And I think you've heard over and over that we need to use protocols and then trust the protocol and not second guess that. To conclude, we have definitely steroids are the most important therapeutic probably we have in perinatal medicine today. There's a tremendous amount of research and effort going on this topic, and you definitely want to stay up to date on this one. And as Dr. DeMartino pointed out, Joint Commission's removed the give steroids to every single pregnant person as a core measure, and hopefully we'll come up with a measure that actually assesses facilities' actual proper timing. And that's the goal SMFM, and maybe one day we'll have that. We definitely want to minimize exposure to steroids for patients that we think will go on to deliver at term, and we do want to still utilize this medication when we think the patient is at risk of imminent preterm birth. And I would like to conclude with just a couple last little tidbits of information out there. If you have any interest in further educational programs at your own institutions, you want to learn about what you're doing, would you like to, assess quality metrics, you want to improve perinatal outcomes, we would love to either virtually or in person address those needs. And one of our representatives at Hologic is Teresa Mullen. You can reach out to her at teresa.mullen@hologic.com. And we would definitely like to get in touch, whether you'd like us to talk to residents, talk to your OBs, talk to your midwives, family medicine program. Please let us know in regards to that topic.